Hello, ladies. Why are autoimmune diseases so much more common in women? And why do many of them worsen or even appear around menopause? This is not a coincidence. It has a lot to do with how hormones regulate the immune system. And today we're going to break that down clearly with the science to back it up. I'm Dr. Monica Relvis, and in this episode, we are going to cover why autoimmune diseases disproportionately affect women, what actually changes in the immune system during menopause, which conditions are most impacted, and what the research honestly says about hormone therapy. Let's start with the numbers because they're pretty striking. Autoimmune diseases affect roughly 8% of the global population. And here's what most women don't know: nearly 78% of those patients are women. That's not a minor difference, that's a fundamental biological pattern documented across more than 80 distinct conditions. And when you look at specific diseases, the disparity becomes even more pronounced. Systemic lupus erythematosus, or SLE, affects women at an almost 9-to-1 ratio compared to men. Sjogren's disease is 6-to-1. Hashimoto's thyroiditis is nearly 6-to-1. Rheumatoid arthritis is 2-to-1. And multiple sclerosis, which used to be equal, has shifted to approximately 3-to-1 in women over recent decades. These numbers come from peer-reviewed data published in the Journal of Clinical Investigation in 2024, and they're consistent across multiple large-scale studies. So, what is driving this? There are three main factors: sex hormones, genetics, especially the X chromosome effects, and environmental triggers. But today we're going to focus on the hormonal piece because that's where menopause connection lives. And here's a fascinating detail that supports the chromosomal angle. Men who have Klinefelter syndrome, meaning they carry an extra X chromosome, they have significantly elevated autoimmune risk. And that tells us that the X chromosome itself carries immune regulating genes. What does estrogen actually do to the immune system? Most people think of estrogen as a reproductive hormone, but it's also a potent immune modulator. Estrogen receptors, specifically estrogen receptor alpha and beta, are found on virtually every immune cell in the body. T cells, B cells, macrophages, natural killer cells. Estrogen isn't just talking to the ovaries, it's talking to the entire immune system. At physiological levels, estradiol, the primary form of estrogen, can enhance antibody production by B cells, shift immune responses towards a T helper pattern, meaning more antibody driven and less cellular, and increase anti inflammatory signals like interleukin 10 while suppressing some pro inflammatory ones. Now, here is the nuance. This creates a double edged situation. Stronger immune responses are generally good. They mean better defense against infections and stronger vaccine responses as well. But a more reactive immune system also carries a higher risk of autoimmune reactions where the body starts attacking itself. And estrogen's effects are dose and context dependent. This matters when we get to the hormone therapy conversation. Higher concentrations can actually be pro-inflammatory in certain settings, which is part of why the relationship between estrogen and autoimmunity is so complex. Now let's look at menopause and the immune system, what the research shows, because this is where things get clinically significant. During the menopausal transition, two key hormones decline. Estradiol drops significantly, and progesterone, which actually starts declining earlier, often in the fourth decade of life, also declines sharply. What does this have to do with immune function? A systematic review published in 2010 in Maturitas analyzed 688 studies on menopause and immune function, and it found that after menopause, there is a measurable increase in pro-inflammatory serum markers, specifically interleukin 1, interleukin 6, and TNF alpha. At the same time, there's a decrease in CD4 T lymphocytes and B lymphocytes, and a reduction in the cytotoxic activity of natural killer cells. So, what does all of this mean in plain language? The immune system becomes less regulated and more inflammatory. It has a harder time distinguishing self from non self, which is exactly the problem in autoimmunity. Researchers call this shift inflammaging, a chronic low grade pro inflammatory state that tends to accompany aging, but it is accelerated in women by the estrogen withdrawal of menopause. And this environment can unmask a dormant autoimmune condition or worsen one that was previously stable. So, which diseases are affected the most? Well, let's go through some major conditions here, starting with rheumatoid arthritis. RA affects women at about twice the rate of men. Research shows that early menopause, meaning before the age of 45, is associated with increased RA risk. And women who develop RA after menopause tend to have worse joint damage and faster functional decline. A 2023 cohort study published in RMD Open confirmed that early age at menopause significantly worsens disease outcomes in RA patients. The loss of estrogen's anti-inflammatory effects appears to accelerate joint destruction. Now, moving to multiple sclerosis. MS is a particularly striking example. The female to male ratio in MS has shifted over decades from 1.4 to 1 in 1955 to approximately 3 to 1 in recent data. That kind of change over 60 years points strongly to hormonal and environmental factors, not just genetics. MS often improves during pregnancy, which is when estrogen levels are at their peak. And after menopause, women with MS report increased fatigue and neurological symptoms, which is a finding confirmed in a 2023 review in the International Journal of Women's Health. The immune changes of perimenopause include elevated interleukin 1, interleukin 6, and TNF alpha mirror the inflammatory profile in MS itself. What about lupus? So the relationship with lupus is more complex. SLE has the highest sex disparity of any major autoimmune disease. It's nearly 9 to 1. The disease is most active during reproductive years when estrogen is high. After menopause, flare patterns can shift, but the disease doesn't simply improve. And importantly, SLE can itself affect ovarian function, sometimes contributing to early menopause. And then there's Hashimoto's thyroiditis, which is extremely common in midlife women with close to 6 to 1 female predominance. Declining estrogen may increase thyroid antibody production. Symptoms of fatigue, weight changes, cognitive fog frequently overlap with menopause itself, which can delay or complicate the diagnosis. Now, does hormone therapy prevent autoimmune disease? And here's where I want to be precise, because this is where clinical nuance matters the most. The short answer is no. There is no strong evidence that hormone replacement therapy prevents autoimmune disease. So if someone is telling you that, they're overstating the evidence. But, and this is an important but, research does tell us that hormones influence immune function, and that has real implications for women who already live with these conditions. The question shifts from prevention to what happens to disease activity when hormone levels change, and can restoring them help? Let's talk about HRT and specific diseases. What does the evidence actually say? So let's look at each major condition. Multiple sclerosis. Estrogen has demonstrated neuroprotective properties in both animal models and human studies. Estrogen receptor beta activation specifically suppresses pro-inflammatory cytokine expression. A 2024 debate published in the Multiple Sclerosis Journal with authors from UCLA's neurology department argued for HRT in menopausal MS based on potential cognitive and neuroprotective effects. However, the counterpoint is also well taken. Standard HRT formulations were not designed for neuroprotection. The type and dose of estrogen matter significantly, and the evidence doesn't yet support HRT as a standard MS treatment. It's an active and important area of research. For systemic lupus, this requires the most caution. Evidence from prospective trials suggests a small increased risk of mild to moderate flares in lupus patients on HRT, but the risk of a major flare does not appear to be significantly elevated. A 2025 systematic review in Science Direct defined eligibility criteria for menopausal therapy in lupus, classifying it as potentially appropriate in stable, low risk patients. HRT is generally avoided in patients who have antiphospholipid antibodies due to the thrombotic risk, so it has to be individualized. For rheumatoid arthritis, the picture is more encouraging. HRT does not appear to increase flare in RA, and it may actually improve disease. A 2023 study in the journal Rheumatology found that menopausal women with RA who took HRT alongside standard treatment were more likely to achieve remission compared to those that did not. That's a meaningful finding. What about progesterone? Progesterone was left out of this conversation, and it shouldn't be. Progesterone has genuine anti-inflammatory properties. It lowers pro-inflammatory cytokines and it boosts interleukin 10, which is an anti-inflammatory signal. It suppresses overactive T cell and B cell responses, and critically, it often begins declining before estrogen does, sometimes even a decade earlier. This may explain why some women start noticing immune-related changes in their 40s, well before their final period. Progesterone is not a primary autoimmune treatment, but its immunomodulatory role is recognized in the literature, and it's part of the fuller hormonal picture. So here is the bigger picture. I want to close the clinical section by zooming out because hormones alone do not tell the whole story. Autoimmune risk is shaped by hormones, yes, but also by genetics, including the X chromosome variants and specific immune regulating genes. But the gut microbiome, estrogen helps maintain gut barrier integrity, and perimenopausal changes can increase intestinal permeability, which activates the immune system. And also, environmental exposures, including endocrine disruptors, may amplify immune dysregulation. And metabolic health, adipose tissue produces pro-inflammatory cytokines and converts androgens to estrogen, so body composition matters as well. Hormones are one critical piece of a larger interconnected system. So let me bring it all together. Autoimmune diseases are more common in women for a reason. The immune system is not sex neutral. It is deeply responsive to sex hormones, and the hormonal shifts of menopause can change how it behaves, sometimes unmasking disease, sometimes worsening conditions that were previously well managed. Hormone therapy is not a cure, and it is not a universal solution. For some conditions like rheumatoid arthritis, the current evidence is genuinely encouraging. For others like lupus, it requires careful patient selection and close monitoring. And for multiple sclerosis, the research is evolving in an interesting direction. What the science makes clear is this: understanding these interactions allows clinicians and their patients to make more informed, individualized decisions, and that is always the goal. I'm Dr. Monica Relvis, and thank you for listening.